pero aún hay muchísimas personas que lo utilizan y es la guerra constante para evitar que se siga regando esta falsa información.
People thinking that, once the numbers are down and we reopen businesses and reopen the province, that we're done with it. I think we always have to be vigilant.
Majority of the myths were about where did this COVID came from, why it is happening.
We have therefore made the assessment that COVID-19 can be characterized as a pandemic.
Since the start of the pandemic, there have been many instances of misinformation being spread amongst communities. This episode aims to debunk and address any myths and false information regarding the pandemic, the virus, or any treatments. The pharmacists will provide their insights on any misinformation that is circulating in their countries and explain to you why it is incorrect. Misinformation can negatively impact the progression of the pandemic, and we hope that the following information will provide an understanding of what is fact and what is fiction.
From the people that think that it's not real and it's not a concern and it doesn't affect them. I think that's a myth that's really difficult to debunk. I mean, the other one is people that are anti-mask. Those are a couple of them. That there's other myths include that this is some big conspiracy along the lines of the pandemic documentary or whatever we want to call it that aired early on. I think those are the main ones. I think the other myths are just that it can affect young people, and I think it's not so much a myth as much as it's a misunderstanding, and that comes down to protecting our more at risk. So whether that's people with chronic disease or that might be immunocompromised or just in general the elderly. I think that's the hardest part to overcome for people is that it's a feeling that it's just not about them as an individual, but it's about society as a whole. I mean, it's along those same lines as what vaccination campaigns are all about. It's not about one individual. It's about, the whole herd.
Is around wearing masks, and there's been a lot of conflicting information coming out from different levels of government at different times of the pandemic, and it's as people sort of start to understand and learn more about how this disease is transmitted. And so I recall at the very beginning of February, we had our professional practice conference, and we were very fortunate in order to be able to have Dr. Allison McGeer come and give us a talk about coronaviruses. And at that point, of course, it was sort of, still limited to China, to Wuhan. And so there was, some concern, but not nearly as much concern as we have now. Obviously, it wasn't yet necessarily a global pandemic. And what I recall the most about that discussion was about the talk of masks and how masks weren't really found to be very effective at preventing transmission of a disease, of SARS in the past, let's say, or of other respiratory diseases. And I recall that. And then, and at the beginning of this pandemic, of course, public health was saying sort of the same thing. But what they've come to realize is that, the data is changing. The disease there's more transmission in the community than perhaps was originally anticipated. And so now, of course, the recommendation is to wear masks in any area where you cannot sort of physically distance yourself from other people. And there's been a lot of pushback on that, partly because of the the conflicting information that came out early on, or I should say, it appears to conflict with what was originally sent out in terms of the recommendations around mask wearing. And Canada is not usually a country that has where mask wearing is very common or was very common prior to the pandemic. In fact, nobody essentially wore masks at all, whereas in some other countries it's a bit easier because culturally it tends to be more in favor. It's just sort of the way of doing things and the way that people kind of dealt with these types of illnesses in the past. So it's very difficult to be able to sort of get everybody on board with this idea of mask wearing in public places where you're not able to physically distance yourself from other people. Certainly, what we do know is that the type of mask that people need to wear, even in retail community pharmacies or within a hospital, if you're not providing care to a patient where it might have a risk of aerosolization of the virus, then a surgical mask is sufficient in order to protect you from potential transmission. So we're trying to keep the N95 masks for those really high-risk procedures such as intubation or anything that could result in aerosolization, suctioning, for example. And then, so that, and then now with the cloth face masks, of course, which are, they provide some protection, but certainly not, the same level of protection as an N95, and they're not meant to.
The most common misconception is that it's an old person's disease, and that young people, don't get it, or they don't have to worry about it. And I think what you're seeing now, in July 2020, is that the most significant number of cases around the world are happening in younger people because they're being a little bit, more open, more free, a little bit less sensitive to the social distancing precautions that are being recommended. So that's probably the number one misconception. I think other ones are, the example of the medications that they thought were beneficial. So the hydroxychloroquine, that was probably the biggest one in the past, few weeks that's been dispelled. Besides that, I think that people thinking that, once the numbers are down and we reopen businesses and reopen the province, that we're done with it. I think we always have to be vigilant and just remember that this virus is going to be around for a fairly long time, and it can reside on surfaces, so you have to be careful and then think about that, and that we're not like invincible.
Working all day, almost 24 hours a day. I was always at work, so everything I heard it directly from patients, directly by phone, by email. This is quite recently, but I mean 1 or 2 months ago, about the COVID being an experiment for the mind control of humans, because the vaccine would only be a cover. I think it's called a red flag or false flag, something, a cover up, because they're going to inject some microchip to have control over human mind. So you create a false pandemic virus, and you convince people to vaccine, and instead you're inoculating a microchip to control them, something like that. But okay, this is a very extreme conspiracy. The majority of the myths were about where did this COVID came from, why it is happening. While I found myself most of the time and explained, we know, biologists, virologists know that almost every 100 years, for a biological rule, let's say, that a pandemic virus or microorganisms, pathogens, can spread and develop because it's the nature, let's say so. But this requires a lot of information, studying biology and the other sciences. So you can't really simplify it and explain to people in few words. But yeah, I heard a lot.
Well, of course, there's a lot of talk every day about hydroxychloroquine and its benefits or risks. I'm still out on whether or not there are any benefits versus risks. I do believe that a lot of the risks showed up early on because they were saving it for only the most sick patients. At that point, it was the only thing that they had. And so they were using it in higher doses in hospitalized patients who were unfortunately closer to the end of life, and so a little more inclined to have some severe side effects to it. I have seen some evidence in other countries where lower doses, even weekly doses as opposed to daily doses, are showing some promise in preventing the symptoms of it, but it's not really accepted here at this point. The risks of cardiac side effects are still being outweighed. So that's the number one controversial issue that we've been seeing here.
Well, I think one of the biggest misconceptions that came about in the beginning is that coronavirus would only hurt the adult population, the older adult population, and that if you were young, you were likely to be asymptomatic and get over the infection, and it was not a big deal. And that's not entirely true. We have young adults who experience very significant complications of coronavirus infection. And most recently, the uptick in California is showing the highest prevalence among adults aged 18 to 40, I believe was the category. So very high rates of infection, likely related to the activities that we engage in and the amount of social distancing and precautions that we're taking to prevent the virus spread. Probably one of the biggest challenges is that we were able in California to implement the stay-at-home orders, and most people took that very seriously, and that's why we saw the case rate decline. But now with reopening, it's difficult to manage your behavior to not swing back to all the way back to normal, right? And I think that's the biggest misconception, is reopening doesn't mean going back totally to normal. It means still taking precautions and minimizing our risk in a way that's calculated so that we don't see this resurgence of the virus again.
So I would say early on there was a lot of panic around ACE inhibitors and ibuprofen. So I think that I don't really know where it came from, because it was so early on in the pandemic. I don't know what evidence there was to enforce that. What I would say, I think, is it was based on the kidney risk with these patients. So a lot of patients, when they're critically unwell, one of the first organs to start to fail on ventilation when somebody is just generally requiring a lot of support is the kidneys. So you tend to see certain patients' urine outputs go down. They might need kidney sort of renal replacement therapy, so dialysis to help support their organ function. And NSAIDs, so non-steroidal anti-inflammatories like ibuprofen, and ACE inhibitors, so drugs generally used for sort of hypertension and heart failure, can reduce your kidney function. And I think that's where that link came from, that there was a lot of panic that those drugs If you then developed COVID and you were taking them, you were more likely, I guess, to develop renal failure as a result of that. That has since proven not to be the case at all. And actually the advice has been to continue taking your regular medicines. But it was a very difficult thing to combat in the media, particularly, where it kept coming back into the media, and then another study would be published saying we've got no evidence of this whatsoever, please carry on these treatments. Obviously, if somebody came in clinically dehydrated and unwell in hospital, we hold off on those drugs, but that was no different to how we would manage a patient with an infection normally, or an elderly patient who'd come in with a fall who'd been lying on the floor for several hours or whatever and hadn't been able to drink. And that in itself created problems, because actually what we found out later down the line is that how COVID works, we think, is it's some of its biggest problems are those with cardiovascular risks. So particularly if you then start sort of banding around in the media that they shouldn't take their antihypertensives because it might upset their kidney function, that could have a knock-on effect on their cardiovascular control. And these are patients that probably are in the higher risk category from COVID anyway. The other big, I would say, sort of myth with it, or not so much a myth, but more of a sort of a fuel in this sort of panic and hysteria, was around patients who were immunosuppressed. So either sort of transplant immunosuppression or immunosuppression for sort of autoimmune diseases and things like that, Crohn's disease, rheumatoid arthritis and things like that. Because obviously patients on the immunosuppressants are at greater risk of infection and at greater risk of sort of more severe infection because they haven't got the immune response to manage it. And again, there was a lot in the media and a lot of hysteria of, do they refuse their treatments? A lot of these patients come to hospital for infusions of medication once a month, once every 2 months, something like that. And again, the advice from all the professional bodies was, no, keep taking your treatments. If you're shielding and you're staying safe and you're doing things properly, then the greatest risk to you is losing that control of your normal disease, which might then bring you to hospital, and then you're exposed to patients who might have COVID anyway. And that was then the sort of again, that sort of myth. And there was a lot of patient reassurance. So a number of our sort of community colleagues, I suspect GPs, and also some of the specialist nurses working with these patients probably had spent a lot of time allaying these concerns and reassuring patients that actually the safest thing to do is for them to take their prescribed treatments, because their disease hasn't gone away because of COVID. It's going to put them at higher risk if their normal, well-controlled illness gets worse on top of what is already an overwhelmed healthcare system that can't support, or is trying to minimize the need to support all that other stuff on top of what was going on.
Errores hay muchísimos. Yo escucho de que mi amiga me dijo que hacer gárgaras con limón me va a hacer bien. Hoy me escribió una amiga preguntándome si es que era bueno inyectarse ivermectina. Es más, me han escrito preguntando si se toma ivermectina como profilaxis al COVID-19. Lo nuevo y lo más sonado y lo que más estamos peleando como Asociación Nacional de Químicos y Bioquímicos Farmacéuticos es que se evite que se siga utilizando dióxido de cloro en Ecuador. Sonará tonto, porque en Canadá en el 2010 se prohibió este falso medicamento. Fue igual en Estados Unidos y fue igual en Europa y Reino Unido. Pero en Ecuador se está haciendo muy famoso este dióxido de cloro, que no es otra cosa que un desinfectante que supuestamente destruye el COVID-19. No por alguna investigación, sino porque el consejo del vecino, el consejo de la amiga, y ahora prácticamente hay una gran parte de la población que está tomando este dióxido de cloro. Y estamos en una campaña para poder bloquearlo. Es más, nuestros gobernantes, nuestra asamblea, propuso incluir a este dióxido de cloro como tratamiento para el COVID-19. Fue algo que a toda la comunidad científica del país nos cayó como un balde de agua fría, porque ¿cómo es posible que un asambleísta venga con este tipo de cosas a proponer esto? Para suerte, la autoridad sanitaria se manifestó recomendando no usarlo, pero aún hay muchísimas personas que lo utilizan y es la guerra constante para evitar que se siga regando esta falsa información.
In Africa, we are quite superstitious. Many Africans think there's so many things we believe in that are really not true, you know. So as a pharmacist that encounters a lot of these people on a daily basis, I try to educate and inform them, tell them the real truth about these things, debunk all the myths, debunk all the ideologies they have concerning these things. For example, you hear COVID-19 is a rich man's disease. It cannot affect a poor man. And I'm like, okay, whether you're rich or you're poor, you're still human. If COVID-19 is going to affect you, it will affect you. So it's better you stay safe, prevent getting or catching this virus. By all means, don't say because I'm not so rich, I can't get the virus. Those are part of the myths we get in Nigeria. So I try to debunk that. I try to tell them the real thing about this virus. And then we also get some misconceptions that, oh, once I swallow antibiotics, I'll be cured. Or once I swallow or gargle salt water, I'll be cured. You also get things like once I can eat a lot of ginger, garlic, I'll be cured. You know, a lot of things are just flying up and down on WhatsApp, social media, and all. And then many people tend to believe it. So we try to make them understand that, okay, this is not the way this thing is. This is what you're supposed to do. This is what this is all about. Do you understand? So we try to make them really know what the truth is, because once you can get the truth and once you can understand the truth, you will not be easily swayed by all those information or all those misinformation you get out there. You understand? So those are part of the things we have tried to eradicate, and we also try to make sure drugs are not being abused, because everybody's panicking, everybody's thinking, oh, once I can swallow this drug, I'll be safe. So we're trying to guide especially our antibiotics, we're trying to guide them jealously, trying to make sure rational use is what we do. We don't just use it irrationally. So those are part of things we try to educate the public and make them understand what and what to do.
You probably have read in Canada as well a news on using ACE inhibitors, that is, So our drug information pharmacists, in fact, a group of our, so in Singapore, we do have a cardiology pharmacy specialist together with our drug information pharmacists, and they have come up with all this information to educate the public on this misinformation. And this is actually published in our Singapore Pharmaceutical Society. So if you look at the website, we do have information on this bit, to educate our public on some of the information that they get from the social media. Yeah. And I believe you all know as well, in North America, there are a lot of different treatment come up from the social media, and yeah. So same in Singapore, when they get the information from social media, they will jump into it. And so our pharmacists did come up with some newsletter to educate the public.